Good morning, everyone. You are very welcome to the Irish Cancer Prevention Network webinar, Physical Activity Across the Cancer Continuum. The panel will be delighted to receive any questions you may have. Please use the Q&A feature that is located at the bottom of your PC or laptop screen. If you're using any other digital device today, this may be located elsewhere on the screen or accessed through the More options, which is usually identified by three dots. Now, without further ado, I will hand you over to your host for today, Dr. Trina McCarthy, NCCP. Thank you.
Hello and a very warm welcome to everyone. Delighted to welcome you to our 2025 Awesome Irish Cancer Prevention Network webinar. Just a reminder that today the webinar will be recorded and we'll be able to circulate that in the coming days along with various information resources. We'll have a panel discussion after the three speakers' presentations, but really as you go through, if you want to put your questions in during the webinar, some people will be able to answer those questions in the background, or we can bring those questions to the panel discussion at the end as well. So today's webinar will cover the topic of physical activity across the cancer continuum, looking at primary prevention during treatment and secondary prevention. We really hope that this is offering a unique opportunity for health and social care professionals to increase awareness about physical activity and its important impact on Irish population for primary prevention during cancer treatment and afterwards with secondary prevention. And the purpose really is to help you keep up to date with the latest research and initiatives in this important area of cancer prevention, to help signpost people to services and resources for their use. And it's also an opportunity to network with some key stakeholders. So also just to note, last year with the Department of Health, the HSE's Healthy Eating Active Living Programme launched Every Move Counts, National Physical Activity and Sedentary Behaviour Guidelines for Ireland. And this June then, they launched an extension of these to cover people living with chronic conditions such as cancer. So we'll share these resources with you all following today's webinar along with the webinar recordings. So as I've mentioned already, the webinar today has been organised by the Irish Cancer Prevention Network, and members of the network, the Irish Cancer Prevention Network, or ICPN, collaborate on awareness raising activity in relation to cancer risk reduction and particularly targeting health and social care professionals. And the objective of the ICPN is to contribute to the development of a culture and environment which is conducive to cancer prevention for people living in the Republic of Ireland, thereby reducing the proportions of cancers which are attributed to modifiable risk factors. And before we welcome our first speaker then, we'd like to play you a short video which will give you all an overview of the work of the ICPN.
The Irish Cancer Prevention Network, or ICPN, was formed in 2018 to reduce the impact of cancer on the lives of people in Ireland. Its members support and collaborate on national initiatives around cancer risk reduction. ICPN is made up of Breakthrough Cancer Research, the HSE National Cancer Control Programme, the HSE National Screening Service, Irish Cancer Society and Marie Keating Foundation. Breakthrough Cancer Research fund research, including prevention research, focus on low survival cancers, such as improving management of precancerous conditions like Barrett's esophagus, and provides expertise and patient resources on the impact of diet on cancer. The HSE National Cancer Control Programme works with health service providers and other partners to prevent and treat cancer and increase survival and quality of life by converting knowledge into strategies and actions. The HSE National Screening Service runs 3 population-based cancer screening programs: Bowel Screen, Breast Check and Cervical Check. Their vision is to work together to save lives and improve people's health. The Irish Cancer Society works to ensure that more people learn how to reduce their risk of cancer and detect cancer early, advocates for improved health policies, provides information sessions and delivers national awareness campaigns. The Marie Keating Foundation has a range of awareness and education services focused on reducing cancer risk through lifestyle choices and highlighting signs of common cancers and how to spot cancer early. Cancer prevention is a national effort, and we are confident that together we can continue to raise awareness of cancer risk factors and ensure that people are provided with the information and support they need to adopt healthy lifestyles across Ireland.
And now I'm delighted to introduce our first speaker for today, who's going to speak on physical activity for primary cancer prevention. And that's my colleague, Dr. Breda Neville, who's a consultant in public health medicine, who works on cancer prevention and early diagnosis of cancer in the HSE's National Cancer Control Programme. So over to Breda, thanks.
Today I'm going to speak about physical activity for primary prevention of cancer. So physical activity is defined as any movement that uses skeletal muscles and requires more energy than resting. So this is as distinct from exercise, which is defined as a subset of physical activity that is planned, structured and done repeatedly to improve or maintain physical fitness. Physical activity can be classified by intensity, so light, moderate or vigorous, and intensity is sometimes stratified according to metabolic equivalents or METs. So a MET is a unit used to estimate the amount of energy expended during physical activity relative to resting metabolic rate. So 1 MET is the energy cost of sitting quietly, and it's roughly equivalent to consuming 1 calorie per kilogram of body weight per hour, or 3.5 milliliters of oxygen per kilogram of body weight per hour. So light intensity activities like slow walking are typically less than 3 METs. Moderate intensity activities like brisk walking are usually 3 to 5.9 METs, and vigorous intensity activities such as running are typically greater than or equal to 3 METs. So what is the evidence base for the association between physical activity and cancer risk? The information in this presentation is based on the 3 syntheses of the evidence on physical activity for cancer prevention that you see here on the slide. So on the right is the World Cancer Research Fund and American Institute of Cancer Research expert report, which provided an expert synthesis of the evidence in 2018. The American College of Sports Medicine published the findings from its roundtable exercise to evaluate the evidence on physical activity and cancer prevention in 2019. And on the left, you can see the World Health Organization's International Agency for Research on Cancer, IARC, synthesized the evidence in the chapter on physical activity, sedentary behavior and obesity, which was published in the World Cancer Report in 2020. Research on the association between physical activity and cancer began to emerge initially in the mid to late 1980s. So the early studies focused on athletes and their risk of cancer over a lifetime, as determined through long-term follow-up. In the 40 or so years since, a large body of evidence has amassed. So at the time of publishing the World Cancer Report in 2020, more than 450 observational epidemiological studies had been published that had examined some aspect of physical activity and the risks of developing cancer. And dozens of meta-analyses and systematic reviews had examined the associations for specific cancer sites. In 2016, a pooling study coordinated by the United States National Cancer Institute examined the association between physical activity and cancer for 26 cancer sites by analysing data from 1.44 million participants across 12 large prospective cohort studies from the USA and Europe. In the past 20 years or so, there has been a focus on how sedentary behaviour independent of physical activity is associated with cancer risk. So for practical and ethical reasons, it's not really feasible to conduct randomized control trials to evaluate modifiable risk factors for cancer like physical activity. But RCTs have been carried out to investigate how physical activity influences biomarkers hypothesized to be associated with cancer risk. So the evidence to date has shown that physical activity is associated with a reduced risk of at least 13 types of cancer. So there's strong evidence that physical activity reduces the risk for cancers of the breast, colon, endometrium, bladder, kidney, stomach, and esophagus, so specifically adenocarcinoma of the esophagus. And there's moderate evidence that physical activity reduces the risk of lung cancer. However, with lung cancer, there are concerns around smoking status as a confounding factor. There's limited evidence that physical activity reduces the risk for cancers of the prostate, ovary, pancreas, mouth, pharynx, and larynx. So what about the relationship between sedentary behaviour and cancer risk? So sedentary behaviour is defined as any waking behaviour characterised by an energy expenditure less than or equal to 1.5 METs while in a sitting or reclining posture. So examples include obviously sitting while using a computer, watching TV or reading, or sitting while commuting. And sedentary behaviour is distinct from physical inactivity, as you can meet the guidelines for moderate or physical activity and still spend most of your day sitting. And a growing body of evidence demonstrates that prolonged sedentary behaviour is associated with increased cancer risk independent of physical activity level. Emerging evidence suggests that sedentary behaviour is associated with an increased risk of cancers of the breast, colon, endometrium, and lung. So the World Cancer Research Report describes the evidence for these 4 cancers as limited. And a more recent systematic review and meta-analysis, which was carried out by Hermlink et al. In 2022, which included more studies, found that there was actually no statistically significant association between sedentary behaviour and lung cancer risk. So is it possible to mitigate the risk posed by sedentary behaviour? So there aren't many studies that answer this question with cancer incidence as an outcome. But in terms of mortality, according to a meta-analysis of data from over 1 million people, which was published in The Lancet in 2016, the magnitude of increased risk for all-cause and cancer mortality with increased sitting time is attenuated in physically active people. And those in the most active quartile in the study, so people who engage in moderate intensity physical activity for 60 to 70 minutes per day, have no increased risk of mortality, even if they sit for greater than 8 hours a day. So in fact, those in the most active quartile in the study who sat for more than 8 hours a day had a significantly lower risk of dying during follow-up than those who sat for less than 4 hours per day but were in the least active quartile. Excess mortality was cut by approximately 50% in those engaging in moderate intensity physical activity for approximately 25 to 30 minutes per day, which is in line with the Irish and WHO physical activity guidelines. So risk is attenuated but not entirely eliminated. And then what about breaking up sedentary time with light physical intensity activity? So there's very little direct evidence that breaking up sedentary time reduces cancer risk, but we do know that it affects metabolic pathways that are implicated in cancer development. For example, it improves insulin sensitivity and it reduces inflammation. So how much does physical inactivity contribute to the burden of cancer? A study published in the IMJ in 2020 found that from 2011 to 2015, inadequate physical activity resulted in 1,500 cases of cancer, so that was 5% of the total, and 500 deaths, so 6% of the total deaths. And this equates to 300 cases per year and 100 deaths per year. So only colorectal, breast, and endometrial cancers were considered, which has been typical of previous studies of this kind based on the understanding of the association between physical activity and cancer at the time. As we now know that there are established relationships between physical activity and at least 13 types of cancer, this study is likely to have significantly underestimated the true burden. So further studies will be necessary to estimate the burden in light of the expanding evidence base. There are several hypothesized biological mechanisms involved in the association between physical activity and cancer risk, and randomized control trials have demonstrated direct effects in several of these, so including reduced adiposity. So we know that living with obesity increases the risk of at least 13 types of cancer. Improved metabolic function, so improves insulin sensitivity and lower circulating insulin and insulin-like growth factor. And we know that both insulin and insulin-like growth factor can stimulate increased cell proliferation and inhibit apoptosis or programmed cell death. A reduction in chronic low-grade inflammation and a reduction in circulating sex hormones, which are implicated, for example, in breast and endometrial cancers. So this means that biological plausibility exists for the association between physical activity and cancer risk, which significantly strengthens the evidence. Other hypothesized mechanisms under investigation include improved immune function, improved gut motility, which reduces contact time between potential carcinogens and the intestinal epithelium, and a reduction of oxidative stress, which we know can cause chromosomal abnormalities, DNA damage, and mutations in tumor suppressor genes. So what do we know about the dose and type of physical activity required for cancer prevention? There's consistent evidence that for a dose-response relationship between increasing levels of physical activity and decreasing cancer risk. There's evidence that physical activity is equally beneficial for men and women for cancers of the colon and the kidney. There's limited evidence that effect modification by sex may exist for other cancers such as bladder, gastric, cardia, lung, esophagus, and pancreas. There's insufficient evidence to determine whether the association between physical activity and cancer incidence varies by age or socioeconomic status, and some limited information suggests that the benefits appear to be equal for all racial and ethnic groups. It's not currently possible to determine the exact levels of physical activity needed to provide benefits in reduced cancer incidence for any particular cancer site, and the evidence base has historically been dominated by studies on aerobic exercise, so our understanding of the benefits of resistance training is limited and requires further study. So, in summary, we know that physical activity, aerobic activity specifically, reduces cancer risk, but it's unclear what the optimal type, frequency, intensity, and duration of physical activity for cancer prevention is. So this is taken from the American College of Sports Medicine's Roundtable report, and it illustrates the dose-response relationship between physical activity and cancer. They looked at hazard ratios for 10 cancers from meta-analyses from a review of the evidence carried out by the Physical Activity Guidelines Advisory Committee in 2018, and those are shown in by the black dots, and hazard ratios from the pooled analysis of 1.44 million participants by Moore et al., which I mentioned earlier, and those are shown by the open triangles. So you can see that there is consistency when you compare the results from the meta-analysis to the pooled analysis. The magnitude of risk reduction varied from 10 to 24% when the highest versus lowest levels of physical activity were compared. And you can see that in addition to the cancers that I've already mentioned, liver cancer is also listed here. So the pooled analysis found that higher levels of physical activity were associated with a 36% lower risk of liver cancer compared with lower levels of physical activity. The Physical Advisory Guidelines Committee report didn't include a meta-analysis for liver cancer, so the ACSM concluded that physical activity may protect against liver cancer. You'll also see that melanoma is included. So the pooled analysis found that there was a 27% increased risk of melanoma associated with higher levels of physical activity compared to lower levels. Historically, several cohort studies and meta-analyses reported a positive association between physical activity and melanoma risk, but this association has primarily been attributed to outdoor activities that may expose the skin to UV radiation, which is obviously a key risk factor for melanoma. So awareness of physical activity as a risk factor for cancer amongst the general population is very low. In the National Cancer Survey on Cancer Awareness and Attitudes in 2022, only 1/3 or 33% of participants spontaneously identified low levels of physical activity as a risk factor for cancer. And in keeping with these low levels of awareness, the number of people getting adequate physical activity is also low. So in Ireland, the National Physical Activity and Sedentary Behaviour Guidelines, Every Move Counts, are met by only 1 in 4 primary school children, 1 in 8 teenagers, and 4 in 10 adults. So how much physical activity should people be doing to reduce their risk of cancer? Everyone should follow the National Physical Activity and Sedentary Behaviour Guidelines for Ireland, Every Move Counts. There are different recommendations for different age groups. But so, for example, for adults aged 18 to 65, it is recommended that they get at least 2 hours and 30 minutes of moderate intensity aerobic physical activity, or at least 1 hour and 15 minutes of vigorous intensity aerobic physical activity throughout the week. Additional muscle strengthening activities at moderate or greater intensity that involve all major muscle groups are recommended on 2 or more days a week. Limiting sedentary activity is also a key recommendation across all age groups. So the guidelines recommend limiting sedentary time and time spent sitting and replacing it with any type of movement or physical activity. But the key message is that any activity is better than none, so every move counts. So what are the key take-home messages? So physical inactivity is a modifiable risk factor for cancer. Physical activity is associated with a reduced risk of at least 13 types of cancer, and sedentary behaviour has been identified as an independent risk factor for cancer. Everyone should meet at least the minimum levels of physical activity set out in the National Physical Activity and Sedentary Behaviour Guidelines, Every Move Counts. We know that there is a dose-response relationship between physical activity and cancer risk, so every move counts, but more is better. People should aim to limit sedentary time and interrupt it with short bouts of light physical activity where possible. Those with high levels of sedentary time should aim for even higher levels of physical activity, so in the region of 60 to 75 minutes of moderate intensity physical activity per day. And finally, you should always protect your skin when exercising outdoors. So thank you for your attention, and I'd be happy to take any questions that you may have.
Thanks, Breda. And again, we'll keep those questions till the end when Breda will be able to join us for a panel discussion. So I'm going to introduce our second speaker now. Delighted to welcome Dr. Emer Guinan, who's an Associate Professor in Cancer Rehabilitation and Survivorship at Trinity College Dublin. She's Course Coordinator of Postgraduate Programmes in Cancer Survivorship at TCD, Co-Chair of Trinity St. James's Cancer Institute Cancer Survivorship Network, and Programme Chair of the 4th International Conference on Physiotherapy in Oncology. Her primary research interest is in the role of exercise and rehabilitation in cancer care, particularly in patients with complex rehabilitation needs. And at present, she is the principal investigator on the Personalised Exercise in Cancer Survivorship Programme, which is examining how we can implement exercise into cancer care in Ireland. So I'm delighted to introduce Dr. Guinan now, who's going to speak about physical activity during cancer treatment.
So thank you for the invitation to present to you today. My talk is going to be on physical activity during cancer treatment. And my name is Emer Guinan, and I'm a physiotherapist by background and an associate professor in cancer rehabilitation and survivorship in Trinity College Dublin. So when I think about physical activity during cancer treatment, really to set the scene for today's talk, I went back to the Physical Activity and Cancer Control, or PAC framework. And this was published in 2024. It was an update on the PEACE framework, which many of you may be familiar with. The PEACE framework was originally just the top line of this particular image, which outlined that physical activity can play a role throughout the cancer journey. And it was updated in recent years to really show the growing body of research and literature that we have in this space. So when we look at the during cancer treatment phase of this new PAC framework, we see that they're really talking about these two key areas here, that physical activity plays a role in treatment preparation and coping, and also in treatment effectiveness and coping. And these are in the domains of the pre-treatment, so just preparing somebody as they go in for treatment, and the during treatment phases. And there's lots of different outcomes here that are relevant. So in the pre-treatment phase, we're really looking at kind of delaying any kind of complications or avoiding treatment complications with that. During treatment, we're looking at treatment completion, treatment efficacy, tumor biology in the microenvironment, some really interesting areas of research ongoing in that space. And as with, I suppose, physical activity throughout the cancer trajectory, we expect physical activity during treatment to have the same positive effects on physical health, mental health, psychosocial well-being, and quality of life that we see in other areas. A lot of these programs are delivered in the clinical setting because patients may be unwell as they go through treatment, but through triage models, we may be able to get some patients out into the community as well. And that's good for both the health service, but also for patients in terms of being able to access some of these services. So my talk today is really divided into those two areas. I'm going to talk first about treatment preparation or coping, and then we're going to move into treatment effectiveness and coping. So when I talk about treatment preparation, I'm really talking about this concept of prehabilitation. And many of you on the call today will be very familiar with prehabilitation. Prehabilitation is a really attractive concept. It is this idea that we can optimize or improve a patient's condition in advance of their treatment starting in order to help them cope with the treatment that is to come. And this image here that I've shown is taken from, that top reference there, Durrant and Singh in 2019. And it really is your classic prehabilitation framework. It links back to the Macmillan prehabilitation guidelines as well. And it's that classic concept that when somebody is diagnosed, they come in with that baseline level of fitness. And with prehabilitation, we can make them fitter in the lead up to treatments, typically surgery, okay? Whereas if patients don't get prehabilitation between their diagnosis and their first treatment, their fitness will more or less stay the same. When patients go into treatment, so when they have big surgeries or when they have really cytotoxic treatments such as chemotherapies, we do expect elements of physical health such as fitness or muscle strength to decline. And they will decline whether or not patients have prehabilitation or not. But what we see in the prehabilitation arm is that, I suppose, that magnitude of decline is blunted. It's not as bad. They don't hit the same level of low that you would see in those who do not have prehabilitation. And this is a concept here that we try and blunt the impact of these really harsh treatments on patients by getting them ready before they go in. This paper really talks about, and the whole Macmillan Prehabilitation Guidelines really talk about the prehabilitation-rehabilitation continuum or pathway. And in the ideal, we would like to think that once treatment is over, that we are rehabilitating patients back again, so supporting their recovery. And we can see here the different pathways that are demonstrated with rehabilitation and without rehabilitation. And I suppose the real optimal one is in those patients who are lucky enough to get prehabilitation and then rehabilitation afterwards, that in the ideal, we would be able to bring them back up to a level of fitness or a level of activity or a level of strength that actually exceeds their baseline to support them then as they go on to living with and beyond cancer. So this is the concept, and very visually, I suppose, describes that concept of what we mean by prehabilitation and why it's so attractive as a concept in cancer care. There's no, I suppose, one universal definition that we all fall on for prehabilitation, and that's okay, but there's lots of descriptions out there of what prehabilitation is, and a lot of them tell us the same thing. So the very first one that came out in 2013 described it. Julie Silver has done a huge amount of work in this area in America, a process on the continuum of care that occurs between the time of cancer diagnosis and the beginning of treatment. It includes physical and psychological assessments that establish a baseline functional level, identifies impairments, and provides targeted interventions that improve a patient's health to reduce the incidence and severity of current and future impairment. So this definition really leans on the fact that we know an awful lot of cancer treatments cause impairment. And if we can get measurements completed on patients prospectively or as they go through treatment, we can measure where people start at baseline. We can measure the impact of treatment on known impairments and bring in interventions early and proactively to mitigate that decline. So it reduces the incidence and severity of current and future impairment. And I think that resonates a lot, particularly with physiotherapists who are joining today. The Macmillan 2020 guidelines then, so this is from their Principles and Guidance for Prehabilitation within the management and support of people with cancer. These are currently being updated in the UK, but they have a really nice definition here as well. They describe prehabilitation as something that enables people with cancer to prepare for treatment through promoting healthy behaviours and through needs-based prescribing of exercise, nutrition, and psychological interventions. Prehabilitation is part of a continuum to rehabilitation. We saw that in the diagram I showed you in the earlier slide. And the aims of prehabilitation are to empower patients to maximise resilience to treatment and improve long-term health. So this Macmillan definition takes it a broader view, moves from just outside impairment to looking at that concept that prehabilitation can include lots of different modalities, exercise being one of them. Promoting the prehabilitation to rehabilitation continuum, but still has that core concept that we want to maximize people's health in order to help them withstand treatments that are to come and long-term recovery. So what are the potential benefits? Well, the first thing is to improve physical health to endure or become eligible for cancer treatment. So I've done a lot of work in upper GI cancer. So if you think about somebody going for an esophagectomy, if we can improve their fitness before going for surgery, the concept is, the hypothesis is, that they will be able to better withstand post-operative recovery. In the ideal, we would like to see that they have lower incidence of post-operative complications such as pneumonia, but also that their physical recovery and their ability to engage in ERAS and mobility, post-operative mobility in those early days post-op is better, that the recovery may be better. So that's the ideal, that we would optimize somebody before big surgery and improve their immediate post-operative outcome. There is another role here, of course, as well, because we know that the fitter patients are going into surgery, the less the the lower their risk is of postoperative complications. And as somebody's fitness declines or is lower, their risk of postoperative complications then increases. And at a certain point, it becomes a question, well, is this person fit enough for surgery? So there is a role for prehabilitation in taking people with very low levels of fitness and increasing that fitness to a level where you move them from being at a very high risk of postoperative complications to a much lower risk that maybe the surgeons and anaesthetics are much more comfortable with. So that's your first potential. Your second one then is around improving psychological health to cope with diagnosis and impending cancer treatment. And we see psychological benefits of exercise, for example, but we also see psychology as a key pillar in prehabilitation. We don't have an enormous amount of evidence, and services aren't rolled out internationally as much as we would like, but certainly intuitively, the more psychologically prepared somebody is going in for surgery or big treatments, the better they'll be able to cope with that treatment. So it's very much an evolving area of research. Prevent treatment-induced toxicities and improve treatment completion and recovery. And this speaks back to that whole concept of post-operative complications that I spoke about in the surgery setting. And we'll talk a little bit more later in the presentation about the role of physical activity during treatment to manage some of the immediate toxicities and side effects that can occur with treatments such as chemotherapy. And then one of the really, I suppose, exciting areas of research is this concept or this hypothesis that exercise or physical activity can influence tumor biology and the microenvironment directly to improve treatment efficacy and delay the need for treatment. And again, I'll speak about that more in the coming slides. So where is the evidence on this? So we have lots of feasibility studies that look at, well, can we exercise patients in that really stressful period of time between diagnosis and commencing surgery? Will they adhere? Can we do it? You know, really short, intensive interventions are probably needed there. So we've lots of those types of studies, and we have lots in lung cancer as well. But what we don't have are a huge volume of big randomized control trials. So we have lots of smaller randomized control trials, but not as many big ones as we would like. And these are some of the more recent systematic reviews, scoping reviews, meta-analyses that have been conducted in this space. And they all kind of come down to the same thing, that we need, from a trials perspective, we probably need more big randomized control trials in this space to really prove efficacy. Of course, I would describe prehabilitation sometimes as maybe a little bit of a victim of its own success, because in many countries, surgeons and anaesthetists are very on board with prehabilitation. And that's wonderful. And they're very supportive of prehabilitation programs being rolled out and implemented in their settings. And that makes it very difficult to run a high quality randomized controlled trial where you have a control arm who does not receive any prehabilitation. So it's very intuitive. It makes a huge amount of sense, and clinically patients see and health professionals see lots of very positive outcomes. So I wouldn't let the evidence base in terms of the randomized controlled trials and where we need to go and maybe generate some more be a deterrent here to supporting the concept of prehabilitation, because it is very difficult where we are now to justify why you would have a control group that shouldn't receive prehabilitation in the lead up to big treatments. Of course, prehabilitation is difficult. You know, the idea of prehabilitation is that you exercise somebody from the time they're diagnosed right up to maybe a big surgery that might be their first line of treatment. It's very, very stressful for that patient. We're also talking about, you know, physical activity as a risk factor, as we heard in the first talk, for certain cancers. So we may be dealing with patients who haven't exercised as per normal as part of their routine before they were diagnosed with cancer. So you're trying to introduce something very new. The other big thing are the timelines. There are KPIs, and, you know, surgery has to be completed within a set number of days from the time of diagnosis. And, you know, those KPIs need to be met. So it's a challenge from both a research point of view and from an implementation point of view. And this is an image from a piece of work that was led by one of my really good PhD students, Emily Smith, where she looked at the acceptability of prehabilitation. So is it worth it? Like, is all of this push that we're having, is it being accepted from patients and from health professionals on the ground? And she used a theoretical framework to inform this. And really her results were very interesting, because while it's acknowledged that there's a burden associated with prehabilitation on patients and on families and on health providers trying to deliver those resources in a stressful setting, it is very much seen as an intervention that is worthwhile and that should be promoted, and that efforts should be made to implement it. And from all of her work and all of her findings, some of the key clinical implications are that introduction of services should be comprehensive and clear and right there from the start. It should be very patient-centered, understand that's a high stress time that they're going through, and prioritize accessibility for all. And then finally, that services do need to be appropriately resourced within a clear referral pathway so that it is very easy to embed it within current models. So I suppose while it's difficult, I wouldn't let that be a major deterrent, that we really do need to be pushing this, that patients and health providers are supportive. Real world considerations, of course, it's not possible for everyone to see, resources are stretched. How do we see everybody? There's a model in Manchester, Prehab for Cancer, and has been very, very successful. And they use this kind of triaged or tiered approach. And a lot of us are using this kind of approach across cancer care at the moment, where we recognize that some patients have a higher burden of need or a higher burden of complexity, and they need more specialist input and oversight into things like rehabilitation. Then we'll have those that just need a little bit of extra support, but maybe not as I suppose the level of supervision they may need to be less. And then we've got universal programs that will suit a lot of patients who are otherwise doing well and don't have a huge amount of complexity. And this kind of tiered approach might be something that we consider when we think about implementing prehab programs that are sustainable. The other thing to mention is that in the ideal, rehabilitation doesn't just involve physical activity or exercise. It is one component of that and often provides the kind of steady framework for rehabilitation programs. But in the ideal, we're looking at incorporating nutrition, psychological support, and also education programs that focus on other risk factors such as smoking cessation or alcohol consumption. But of course, that's rehabilitation as we prepare patients for big treatment. What about during treatment? So I'm going to move on to the treatment effectiveness and coping phase of the presentation now. This is a guideline that was published in 2022. Yes, by ASCO, the American Society of Clinical Oncology. Now, ASCO is the big international organization from where all of our clinical oncologists get their guidance on best practice. Okay, so for ASCO to publish this guideline has huge impact for us in the exercise oncology world. They recommend that oncology providers should provide aerobic and resistance training, exercise training, during active treatment with curative intent to mitigate side effects of cancer treatment. Exercise interventions during active treatment reduce cancer-related fatigue, preserve cardiorespiratory fitness, physical functioning and strength, improve health-related quality of life, reduce anxiety and depression in some populations, and have low risk of adverse events. So concerns are alleviated. So this is really important. This is getting the oncologists in particular behind the exercise community in terms of promoting physical activity during treatment. So what are the benefits? And there's a huge amount of ongoing work in this space. So I'm actually just going to start at point 5 because this is where we have a lot of randomized trials. And we know that there are lots of benefits to exercising during and after active treatment that promote physical well-being, psychological outcomes and quality of life for patients. And I would say that we have very, very strong evidence from clinical trials to support that. Some of the areas then of emerging interest are, well, we observe better outcomes in patients who can maintain their physical activity during and after treatment. And why is that? What are some of the biological mechanisms underpinning that? And points 1 to 4 really speak to this. So it is hypothesized that exercise can have a direct effect on tumor growth and metastases through lots of different pathways that we can that are being investigated at the minute. Is it through pro-inflammatory pathways, immune suppression, etc.? Improved treatment completion rates, and we have a number of trials in this space which have really looked at exercise during adjuvant treatment, particularly chemotherapy, and have described that patients who complete particularly aerobic and resistance training exercise have higher completion rates of chemotherapy in comparison to those who do not exercise or who maybe just complete aerobic exercise alone. That resistance exercise has an important role to play here. And that's really important because if we can support patients to complete their chemotherapy to a higher level, that's good in terms of the impact that that chemotherapy can have. There are trials, these are emerging trials, and we don't have a critical mass of literature in this space, but it's one hypothesis that's been tested repeatedly. Improve treatment efficacy. And this is, I suppose, the really novel area of research that's ongoing at the minute. So this is particularly driven through what we would call angiogenesis, or the ability of cancer tumours to generate their own blood supply. And normally when tumours do this, the blood vessels that they generate are kind of leaky and porous and don't function very well. With exercise, the integrity and the structure of those blood vessels can be improved, which reduces hypoxia or improves oxygenation to the tumour, but ultimately improves chemotherapy delivery to the tumour. And this is the area that an awful lot of groups around the world are looking at the minute. Can we improve chemotherapy delivery through the tumour, through improved angiogenesis of the tumour? Through exercise programming during cancer treatment. So I'd say watch this space to see the emerging literature that comes out in this area. And then management of treatment-induced toxicities, such as cancer-related fatigue. So we know that inflammation is something that exercise can target, and by reducing inflammation through exercise, that can have a knock-on effect on things like cancer-related fatigue, which is higher with higher levels of inflammation. So we see all of these, the state of the evidence, I suppose, summarised in the ACSM exercise guidelines for cancer survivors. This was published in 2019. We have really strong evidence from clinical trials across a number of different outcomes: anxiety, depression, fatigue, health-related quality of life, and perceived physical functioning, all improved with aerobic and resistance exercise. And we have emerging evidence in a lot of these spaces down at the bottom. So I talked about treatment tolerance in particular there, but there are other areas ongoing, such as cardiotoxicity and chemotherapy-induced peripheral neuropathy, etc. So these are, I suppose, areas that I keep an eye on these trials. We may see an update into this in the next iteration of this roundtable. But of course, exercise during treatment is really tough. And anyone working clinically with patients will be like, how do I do this? We looked at, I suppose, the implementation challenges of exercise trials during treatment. And this is another PhD student of mine, Neil Kearney, and he did some really nice work here. And looking at the trials that have already been completed that are providing us with the evidence in this space, we see that patients prefer, have higher recruitment rates for home-based exercise programs, so they prefer home-based, but retention on those trials where they don't have that in-person support tends to be trickier. So we need to balance there. We get higher adherence for aerobic exercise than for resistance training exercise, and that can often be what patients are more comfortable with, but we know that resistance training exercise is very important in this group, so that's another challenge. What we also see is that exercise programs lack periodization, so they lack almost a planned application of clinical reasoning, that while patients are going through chemotherapy and they're feeling unwell after certain cycles, and then they may feel better the following week, exercise programs need to follow that pattern, need to work with patients so that they're flexible in how they schedule programs. And an awful lot of the trials that are published already lack diversity, so in terms of basic demographics, but also in terms of cancer type. So we need to learn more about an awful lot more cancers to really be able to implement this into practice. And one of the big things that we're running now, that Neil is running in St. James's, is the FIRST trial, which worked with patients and other healthcare providers to design a very flexible type of program, which is very, very patient controlled. So allowing flexible scheduling of exercise programming during chemotherapy, patient controlled in terms of the level of intensity that they want to reach, maps to their treatment cycles, and is based on their own symptom monitoring to provide them with the control and the understanding of how they can exercise in the context of having lots of different cancer symptoms. So our protocol for that is published. So we'll see how that program works for patients as we analyze results towards the end of the year. So I'd like to thank you for your attention and just flag that we have a lot of resource and a lot of service mapping done on www.cancerrehabilitation.ie, where you'll find more details to follow on from today. So thank you very much.
Thanks to Emer for that presentation. I'm sure there'll be lots of questions to discuss with the panel at the end. So now I'm just going to bring us on to our final presentation for today and introduce Dr. Gráinne Shiel, who's an adjunct assistant professor in Trinity College Dublin and a clinical specialist physiotherapist in cancer rehabilitation in the Trinity St. James's Cancer Institute. She completed her PhD and postdoctoral training in exercise oncology in Trinity College Dublin, and her main research interest is in the implementation of cancer rehabilitation into clinical practice. Dr. Shiel is currently working on an emerging clinician scientist award from the Irish Health Research Board to develop a rehabilitation pathway for patients undergoing stem cell transplants. So very happy to introduce Dr. Gráinne Shiel, who's going to speak to us about physical activity, living with and beyond cancer. Over to you, Gráinne.
Hi, my name is Gráinne Shiel. I'm a clinical specialist physiotherapist in cancer rehabilitation in St. James's and an adjunct assistant professor in Trinity. And today I will give a talk focused on the secondary prevention of cancer, the role of physical activity. So it's an important area, and I guess we're encouraging all of our patients to be active like during and after cancer for the quality of life benefits and so on. But we're learning more and more about the role of exercise in actually managing disease. And you can see here outcomes from a systematic review that looked at physical activity in 36 different studies, but it was nearly 70,000 patients. And what they found was there's a positive role in terms of exercise in terms of cancer recurrence. And you can see there 21 to 35%, depending on the cancer type that you look at and the type of study, cancer mortality, and then all-cause mortality as well. So what we're trying now to grapple with is, well, what is the evidence for those different cancers, and how can we best prescribe exercise to patients after treatment with their overall health and survival in mind. This is a little bit more recent, and this looked at the broader term of physical activity. Obviously, exercise is a subset of that. And with 136 studies, they looked at physical activity across the board. So total physical activity, but that included recreational physical activity and/or leisure time, transportation, occupational and household physical activity. And what they found in this paper was that the post-diagnosis physical activity was associated with greater reductions in cancer-specific and all-cause mortality. And you can see that 30% of reduction mentioned there in some of those cancers. And traditionally, the strongest evidence has been in breast, colorectal, and prostate cancer. But this review, I guess, is starting that conversation outside of those cancer types in terms of gynae cancers, kidney cancer, stomach cancers, and lung. So when we look at specific tumor groups, then this is one of the studies, say, that would have been included in these previous reviews. And this just gives an idea of how these studies are structured. So this is taken from the Harvard Health Professionals study. This study has run for nearly 50 years and has about 50,000 people completing data entry for the study. And a subset of that population has been diagnosed with prostate cancer. So what they were able to do with those kind of 2,500 men that have a diagnosis of prostate cancer is go back and look at, well, what about physical activity, and then look forward and track over time, well, what about their physical activity after they were diagnosed. So they had a sample of about 2,500 men, and they looked at over time what happened to those who were more active. And they used kind of walking as their measure. They used, here you can see walking speed and walking duration. And they found that men that had over so the cutoff of 9 MET hours a week, they had a 33% reduction in all-cause mortality. So we're seeing this pattern here of those who are more active doing better in the longer term. And then the paper went a little bit further and said for each increasing category of total activity, it was associated with decreased risk of all-cause mortality. So the people who did more and the people who engaged in that more vigorous type, moderate to vigorous type of activity did better as well. So what they're concluding here, both kind of, you can see on the left the descriptions for all-cause mortality and prostate cancer mortality, that a modest amount of vigorous activity, and they give examples of anything really that raises the heart rate, gets people a little bit breathless, biking, swimming, jogging, for more than 3 hours a week, and that can substantially improve prostate cancer specific survival. So again, we have, I suppose, a number of these observational papers now where they're following people over time and asking for self-report. And there's limitations with that data, although it's encouraging and it really sets a scene for this to be examined in more detail. It is, I suppose, reported by the patient over time. And thankfully, in recent months, so this is in July 2025, and this was presented at ASCO this year, there's the challenge trial. And this is a trial that actually enrolled patients into a randomized control trial to examine this question in a little bit more detail. In patients with colon cancer, what is the effect of this structured exercise? So again, it was building on observational studies. The study ran for a period of over 13 years with a kind of a median follow-up of 10 years. So it was a huge undertaking, and it did run in 55 centres, mainly between Canada and Australia, but that did allow them to accrue their target population of 889 participants. All patients had a resected colon cancer and who had started their adjuvant chemotherapy. So within 6 months of their surgery, they were to start chemotherapy. They were split into 2 groups. One was a structured exercise program, which I'll give a little bit more detail about in a minute, and one was health education materials alone. The duration of the intervention was over a 3-year period, and like that, it's relevant here as this is one of the first studies where the primary endpoint was disease-free survival. So we'll talk a little bit about the exercise program. I guess the health education materials alone was based around a physical activity and diet booklet. So the exercise intervention then again was running over different phases. In the first 6 months, the patients got 12 mandatory in-person behavioural support sessions, and they were every 2 weeks. And the type of thing that was included in this was discussions around barriers to physical activity. How could we overcome barriers, and what social supports are available to help with physical activity, time management, how patients can self-monitor their physical activity, how they can make goals. They completed decisional balance sheets, and they did a lot of work around self-reinforcement. They, with that, then completed their 12 mandatory supervised exercise sessions, and they were also advised to complete a further 12 sessions on the alternate weeks to the mandatory sessions. In phase 2, so after that initial 6 months, there was a mandatory behavioural support sessions and a supervised session only if the patient attended the behavioural support in person. And that continued then for the following 2 years, except the frequency of the intervention decreased to once a month. They gave quite detailed data on the adherence to different aspects of the program. So you can see here I've just included the kind of the mean adherence for those initial components of the exercise intervention. They do go into great detail about the further 2 years as well. The goal of the program really was to increase recreational aerobic exercise. So that's exercise where the body is moving, where patients are getting a little bit warmer, a little bit sweaty, their breathing changes. And they wanted to do that by at least 10 metabolic equivalent task hours per week for the first 6 months. And then any decision to add additional kind of med hours after that was made on a case-by-case basis. So the outcomes then for the study, the follow-up went over 10 years. So they really have, I guess, shown here a lot of detail about disease-free survival. So you can see here the curves really match for the first year, and then they start to separate. And at 5 years, the difference was 6.4 percentage points between the two groups, the exercise and the health education group. So their summary was that the exercise significantly reduced the relative risk of disease recurrence, new primary cancer, or death by 28%. They also gave information on overall survival of the two groups. And again, you can see for 4 years, the curves do not separate. However, at that point, they do. And then you can see the percentage points in the difference described later on. And their summary here was that exercise reduced the relative risk of death by 37%. So the conclusions then for this trial, which, as we've said, is one of the largest to look at overall survival in an exercise study, were that the benefits of exercise came from improved cancer outcomes. They did see reduced risk of recurrence in those in the exercise group. The exercise intervention resulted in meaningful improvements in cardiorespiratory fitness and physical functioning. Although that wasn't the primary outcome, they did do vigorous measures of submaximal exercise intensity in the seniors fitness test. And exercise did not reduce body weight or waist circumference, so they feel the results are independent of weight management. They have outlined that the magnitude of the benefit from the exercise intervention delivered after surgery and chemo was similar to that of many currently approved standard drug treatments. So very strong support for the role of exercise in this population following their cancer treatment. The summary is that this 3-year program was led to improvements in disease-free survival. So I guess then the question is, well, how do we start to implement this into clinical practice? And how do we ensure that patients that are on similar treatments, and about 60% of this group were on FOLFOX, how do we allow them then to access some of the benefits that the exercise is associated with? And that's what we're trying to do in clinical practice. So we have guidelines, and we have guidelines around aerobic exercise and strength exercise that really match what was prescribed in the challenge trial. So engaging in aerobic exercise to the point where you're accumulating about 150 minutes a week of that moderate intensity. And there are additional benefits for strength training, and that hasn't been described in the previous paper, but all patients are encouraged to complete strength exercise twice per week. So 2 sets of 8 to 15 reps, so 8 to 15 repetitions of each exercise is what we try to aim for. And for some patients, this is really challenging. This is very far from where they're starting from after treatment. But our main message is to avoid inactivity. So although we know the greatest benefits are associated with this level of activity, our main message for patients when we meet them often is avoid inactivity, and this is something that we kind of aspire to reach. Why is it difficult? Well, I guess when we see patients after they've had treatment, so for example, if they had surgery and adjuvant chemo, such as the patients in the challenge trial, they may or may not present with some cancer-related impairments, and some of those are described here. So they may or may not present with cancer-related pain or cancer-related fatigue in the acute phase, but also these can be persistent and they can last in the longer term. So these can be barriers to physical activity or challenges, I guess, to the patients increasing their physical activity levels. And often it's not until we address these barriers that we can meaningfully engage patients in a physical activity program. So we I suppose have to be able to assess patients and see where they are in terms of any cancer-related impairments and address those, because we know there's substantial benefits. So the American College of Sports Medicine guidelines that I just mentioned have outlined multiple benefits, and I've just picked 3 here. 2 of them are psychological benefits of exercise. One is around anxiety, and the other is around depressive symptoms. So we know that patients who are experiencing difficulties in this area will benefit from engaging in physical activity. For both, it seems that a moderate intensity program combining aerobic and strength is best, or aerobic on its own. There doesn't appear to be a benefit of just engaging in strength exercise. And again, we start to see this concept of a dose-response relationship emerge here, where perhaps, particularly for depressive symptoms, patients who do more will experience more benefit. And then the exercise guidelines talk about supervision. So we're thinking again, if these are the symptoms patients are presenting with, and we look to the evidence, those that are offered supervised sessions tend to do better. This is in contrast to fatigue, which is probably the most common symptom that we would see as a kind of a barrier to physical activity. And I suppose that is in keeping with the literature that would show this is the most common symptom that patients will report. And it can also be quite persistent. So I guess what we're trying to understand now is, well, what's the best exercise prescription or physical activity recommendation that we can give patients with fatigue? And it appears any exercise is positive, a combination of any exercise is positive. The intensity of exercise is important, so we would encourage patients to reach that moderate intensity where they get a little bit warm, a little bit sweaty, and a little bit out of breath, rather than doing perhaps a very gentle walk at a lower intensity for a longer period. We would scale that back and work on the a higher intensity. And the efficacy or the effect of exercise appears to be independent of the level of supervision. So for a lot of these patients, we're really counseling, giving them education and advice in the context of physical activity, and giving them programs that they can either work on themselves or work on with us. And in James's, when we're trying to engage more and more people in physical activity after treatment, it really is trying to do a thorough assessment on someone. So you can pick up, well, what are those impairments? What are those potential barriers to physical activity? And then we can make better decisions about the type of support that those patients need to be active. So for example, if patients present with a number of impairments that need one-to-one input, we will keep those patients with perhaps an exercise professional that they can see one-on-one. So this would be something like a peripheral neuropathy that affects patients' balance or sensory input that might put them at risk of falls when they're being physically active. Perhaps after balance re-education and sensory re-education, that patient will be much more aware of their the suitable exercises for them, and indeed they might be able to engage in physical activity or exercises that they weren't before their rehab. So that's an example of someone that we might try and keep with the goal of getting them more physically active. Others need supervision, and then they might need small group programs. And of course, our goal is really to get everybody out into the community, walking themselves, walking with friends, back doing activity or exercise that they did perhaps before their diagnosis or their treatment. And for some patients, they will need community exercise supports, and linking patients in with those can be a really nice way to ensure that there's a long-term plan in place for their physical activity and exercise. And we see in the challenge trial that the intervention was 3 years long. And of course, you're trying, when you refer to someone or when you're making a physical activity plan with someone, to ensure that it's something that has longevity, that the patients will continue in the longer term. And that's why we look at some of these options. In terms of patients who need, I suppose, rehab before engaging in physical activity, we would see this a lot with these specific impairments mentioned here. But they're not there's no reason why patients shouldn't be physically active. Indeed, there's more evidence, I suppose, in terms of the role of physical activity with some of these conditions, but they might need additional supports and information and guidance. When we do implement that kind of tiered system of like stepped care, where we're trying to connect patients with the right intervention, this is results from the Irish Cancer Society PERC study. And what we can see is that about 60% will go out to the community. But we also saw that nearly 90% of patients were very happy to receive exercise information and advice even up to 2 years after their treatment. So we see a need for this kind of counselling or this assessment and advice for patients. And then we've seen not all patients will need, I suppose, the highest level of care. We do have a lot of community options, and really this is about making the connection. And when we do connect patients to the right level of physical activity guidance and information, we can see that it has really marked benefits. So pink is before patients were connected with an exercise program, and blue is after 12 weeks when they came back to be reassessed. We saw improvements in strength, aerobic endurance, and so on. So really what we're trying to do now is highlight the body of evidence that's really supports the role of exercise for people kind of living beyond cancer. But specifically, there is evidence to support the role of structured physical activity as a tool in secondary cancer prevention. And we've outlined some of the evidence for that today, mostly in the area of colon, breast, and prostate cancer, but that's constantly expanding. And some patients, in order for them to get the benefits that are described in terms of secondary prevention, will need that connection to exercise support and guidance and supportive care really around physical activity before they will kind of engage following treatment. Thank you.
Thanks for that, Sheila, or Grania, apologies. And I'd like to invite the 3 speakers from today just to join us for a panel discussion. So again, Dr. Breda Neville, Dr. Emer Guinan, and Dr. Grania Shiel. And we might just start with you, Breda, and I suppose just going back to, what causes cancer in the first place and what we can do to advise people, how to reduce their risk. And in terms of interaction with any other modifiable risk factors, is there any synergistic effect or otherwise between physical activity and other factors like diet, body weight, or alcohol intake?
Yeah, so I suppose, like as you've alluded to there, Sheena, we know that things like poor diet, living with obesity, and consuming alcohol are all independent risk factors in and of themselves. In terms of interaction, I suppose, particularly thinking about obesity, so we know that obesity is a complex condition, but having said that, we still do know that physical activity levels, diet, and alcohol consumption all influence body weight, particularly before someone develops obesity. So when there's still an opportunity for obesity prevention. And also, like a lot of the biological mechanisms through which obesity and physical inactivity are thought to increase cancer risk are the same. So things like reduced insulin sensitivity, higher levels of circulating hormones, and inflammation. And physical activity helps to mitigate those to an extent, even when people are living with obesity. So while ideally, you'd have a healthy body weight and be physically active, a person who's living with obesity and physically active is still at a lower risk than someone who's living with obesity who is inactive.
They'll still get the benefits and it's still worth, yeah.
Yeah, absolutely.
No, that's really helpful. And just in terms of, I suppose, the advice then for the benefit of physical activity in reducing your risk, just again to you, Breda, I mean, is there any difference in terms of the stage of life somebody is at or their race or ethnicity? Is it more important for particular groups of people, or is it a very just broad general recommendation?
Yeah, so at the moment, the evidence on that is it's quite limited. So in general, there does appear to be a protective effect across all ages, sexes, and racial and ethnic groups. But I suppose the magnitude of the association may vary by group or by cancer site. But we don't have sufficient evidence yet to draw conclusions on how it may vary. So I suppose the bottom line is it's likely that there's a protective effect for everyone that may be different for some cancers and in some age groups. We don't fully understand that yet.
Okay, so there'll be more research in the future, I'm sure, to tell us more, but still a good recommendation for everybody.
Absolutely.
And can I go to Grania next, if you don't mind, just in terms of I suppose the terms physical activity and exercise being maybe a subset of physical activity. Could you explain that a little bit more in terms of the difference when you're making those recommendations, what you mean by that?
Yeah, so when we're talking to patients, we start with talking about physical activity mostly, if we're talking about exercise, particularly for someone who's been inactive. And what we would encourage is that all patients are physically active. So we would talk to patients about going for a walk, for example. And some patients say, yeah, I am active. And you would say to them, well, when you say go on your walk, do you start to feel you know, a little bit warmer? Does your breathing change? Do you come back in a little bit clammier than when you went out? And then you're trying to kind of figure out, are they getting actually to moderate intensity? Are they increasing their heart rate, or are they working a little bit harder when they're being physically active? And it really then kind of can inform the conversation around exercise. And exercise is something maybe that we give as a plan for the patient. So it's more structured. So we would say so many times of the week, we want you to exercise and do this particular thing. And we'll talk to them about the intensity of that exercise, how long we'd like that to last for. And if it's resistance exercise, then we will make a specific plan around these are the type of exercises that you might do. Your legs seem weak or your arms seem weak, and this is why what I would advise you to do about that. So it's really a kind of a conversation with the patient. For some patients, we might just talk about physical activity, and trying to kind of get a more I suppose it's more prescribed program in place. And for other patients, we'll go into great detail about exercise, exercise plan for the week, and a more specific prescription with aerobic and resistance exercise, and sometimes balance and flexibility exercises as well, if that's what's needed for those patients. So yeah, some patients do think it's the same, you know, it's the same thing, and we don't get too caught up in the terms, but we do try and talk through it with people.
Okay, and just to say with you, Gráinne, in terms of, I suppose, practical activities, you know, kind of everyday activities that people could do, you know, maybe if they're not as interested in engaging with things outside of the home or group activity
Yeah.
or that, you know, is that something that you'd see as part of the approach as well?
Yeah, absolutely. I mean, we're trying to think of something that's going to be sustainable, that the patient is going to engage in, and that there's going to be longevity in it. So we would talk to patients about kind of activity around the house. How many times do you go up and down the stairs? Could you use more, could you use the stairs more often? Could you start walking somewhere that you currently don't walk to? You drive, if you're driving at the moment, or if you are taking public transport, could you maybe get off a stop earlier or walk a stop later and increase your physical activity levels through that? So there's lots of practical kind of ways during the day that we can encourage patients to be physically active. Again, it just depends on where the patient is starting from. And for some patients, that can be a significant increase in their activity levels.
Okay, that's really helpful. And Emer, if I could bring you in around, you spoke very eloquently about the evidence for prehabilitation, exercise prehabilitation, and I suppose the strength of that evidence. And I suppose we had a few questions, particularly around, you know, are there any such programs in place in Ireland currently? You know, what options are there in place now, I suppose, that it would be useful for attendees to know about?
Yeah, that's the tricky bit, isn't it? When you're
Yeah.
presenting the evidence and then, you know, what resources
We
are
do.
there.
Yeah.
Yeah, so look, in St. James's Hospital, there is the prehabilitation program has been in place since I think 2019. Gráinne, correct me if I'm wrong. And it receives over 700, maybe 800 referrals a year. So they're delivering a high volume prehabilitation service, and a lot of it is delivered virtually. Now that's one example, and not everybody attends St. James's Hospital. And I suppose part of the work that we're trying to do at the moment through Perks is to raise awareness of some of the gaps that we have in services, and lobby for more services. So I suppose what we have done as part of the Perks program that Gráinne spoke about as well is create the website, which includes a service directory. And that service directory is mapped across the country. So the website is cancerrehabilitation.ie. And I suppose people can use that to find out what services might be available to them locally. Some are community-based, so you've got, good community programs like XWell and Ciel Bleu. Ireland Active have been sending people to become trained, can rehab trained, providing more services around the country as well. And we're currently updating that service directory. So I suppose if there's anyone on the call that provides a prehab service, because this is a question that comes up a lot, getting in touch with us to have your service listed there, because, unless we can collate and keep updating, that information, it is difficult for people to find those services.
Thanks for that, Emer. And I suppose particularly to stay with you then, particularly when people are undergoing treatment and maybe unwell because of treatment, I mean, are there, what kind of adaptations are necessary, I suppose, to the type of exercise and activity that they engage in?
Yeah. And I mean, look, while on treatment, I know I focused on chemotherapy, and that's where, we're doing some work at the moment. Symptoms, fluctuate, and people have good days and people have bad days. And when we were designing the Fierce program, we worked, I suppose we were informed by the literature, worked a lot with nursing staff and physiotherapy staff at St. James's, and worked a lot with patients to see how we would manage exercise prescription in the context of people feeling unwell and fluctuating symptoms. And the approach that we take is to think about an overall exercise volume. So instead of saying that somebody needs to do X number of exercise sessions per week, we think about, right, over the cycle of their chemotherapy, we try and get them to complete an overall volume of exercise. And that may mean that there's a week where, when they're very symptomatic, that they're not feeling great, that we lessen, I suppose, the demands in terms of exercise. And as Gráinne spoke to, it might be a thing that we encourage people to just be as active as they can within their own homes, or, within their own immediate area. And I suppose encourage that as something better than nothing. And then on the days when they're feeling better, that we use that opportunity to increase the level of physical activity or exercise that they're doing. So that's, I suppose, what we would call a kind of more of a periodized approach, where we're trying to plan. We know that there's going to be fluctuations in symptoms, and we try to plan, the good days and the bad days, and map the volume a little with that. We do encourage patients to take a lot of responsibility for that themselves. We do a lot of work at the start around understanding your symptoms, and listening to your body, and using the Borg rate of perceived exertion, so that exercise prescription is not overly complicated, that they can exercise to that moderate intensity that Gráinne was talking about, but they understand it themselves and they can get there themselves. So we spend a lot of time educating patients so they can support themselves to do that during chemo, and that seems to be working. It seems to be helping, and I suppose having flexibility in the types of scheduling that we do. So we offer supervised programs, but we also encourage home-based exercise sessions, so people incorporating it in a way that works for them.
And I suppose with what you said there about the fluctuation in symptoms, would that be one of the main barriers in terms of getting people to engage with these kind of programs during their treatment?
Yeah, I think one of the big things we learned from a lot of the PPI work, the patient work that we did in preparing Fierce, was that when patients are feeling unwell, and they miss, their planned physical activity or exercise session, that starts to feel like a little bit of a failure, kind of, oh, I wasn't feeling well that week and I wasn't able to do it, and now it's hard to get back on track. Can I get back on track? So yes, those fluctuating symptoms and the low days are definitely a barrier, and can become a problem if we're not talking to patients from the start and saying, look, it's okay to have those rest days and to listen to your body on those days, and that we're aiming for an overall, and
so the expectations are set kind of early on, and
exactly. Yeah, so that helps.
That seems to work. That's great. I might just come towards maybe our last question, really. I know, Gráinne, if I could come back to you, you mentioned because there are quite a few things someone living with and beyond cancer can have a lot of challenges that you mentioned, that might put them off or make them nervous about doing exercise. They might have a neuropathy, be worried about falling, or have lymphedema. There could be some kind of very specific barriers. So, I mean, if someone is worried about taking up physical activity, and where should we be directing them to, or where can they be signposted to, I suppose, for support? Where can they get advice on that?
I think it really, some of the information depends on the centers that they're in, but I think broadly we have to go back to some of the resources that have been mentioned already, and that is maybe through the website you can get further signposting, but those national organizations like like XWell and CL Blue. And even now that there's more knowledge around cancer, I know I see the local sports partnerships mentioned there, and we would, like from James's, we're based in Dublin, we would be consistently looking for places to refer patients that are outside Dublin that are looking for, guidance and supervision. So thankfully, in the last year or two, there are more options for us to refer patients out to. But potentially, as a first port of call, the website might provide some signposting as to where patients can go. And then any of those community exercise organizations would be a great place to contact. I'm just very conscious, a lot of patients will be able to exercise in the community setting with a little bit of support and guidance, but really it's more giving them confidence to start to be active again after their treatment is finished. Potentially they're in a very different place to where they were before treatment started, and that can be very daunting. So a lot of the time it's really just around messaging that physical activity is really, it's quite safe. It's something that will be really beneficial for you to do. And any healthcare professional, I think, can give that messaging to the patient and encourage the patient to start, with whatever activity they feel able to do. And then if there's specific impairments, they can look for further supports. And I guess if they really have barriers that are really stopping them from exercising, often it can need an individualized assessment. And for those patients, you're trying to look for a physiotherapist or an exercise professional with specific exercise knowledge in cancer care. And that one-on-one assessment will need to be done with the health professional with that experience. So I'm thinking of some of the things you've mentioned, or perhaps patients with advanced disease or bone metastases, they might just need someone to give them a specific program for themselves. So if it's on that level, then it is to look for a registered physiotherapist.
Okay, but as you say, that's probably going to be the minority of people that would be an option when required. But for most people, it's kind of down for all health and social care professionals to be the person to kind of assure and encourage physical activity.
And let them know that the evidence is there to kind of support the benefits of them getting back to physical activity, and even just encouraging them to start somewhere. Because as I say, one of the biggest things we see is that patients feel a little bit lost because they can be very far from where they started, and it can feel wrong almost exercising again because it feels different, whereas actually that's just getting moving again.
Great. Well, I think that's a great message to end our panel discussion on, and I think it's been great really to see the just the strength of the evidence. I think just right across the continuum, both from risk reduction to benefits, prior to treatment, during treatment, and living beyond cancer as well. So I'd just like to say thank you to our panelists for both their presentations today, and also for partaking in the Q&A. Really, as I said, engaging presentations. I'd also like to thank the Irish Cancer Prevention Network members, and just by way of closing, I suppose, just to remind people, if you're not already signed up for our quarterly zine, you can do that on irishcancerpreventionnetwork.com. For those of you who are working with patients and clients and would like resources on cancer prevention, just to let you know that you can get those on healthpromotion.ie. So if you actually search under the term health, you'll be able to see a lot of resources there. And also Emer, who presented to us today, kindly did one of the HSE Talking Health and Wellbeing podcasts recently on the topic of physical activity across the cancer continuum. So that will be released fairly soon. I think it should be out on the 22nd of October, if I'm not mistaken. So we'll circulate that and let you know when that's available as well as sharing again the recording of the talks from today. So I'd just like to bring today's webinar to a close, and thank you all for attending, for your questions, and very engaging questions as well that were shared. And thank you to our panelists. And again, we'd be very interested in knowing as well what other topics you'd like to see covered at future webinars. So we'd really appreciate that feedback. So thank you to everyone for taking part today.